Yeah, so I think, so the question is, how can the guidelines be approved? I've served on guidelines committees. It's challenging. You have to rely on available evidence, and available evidence is to make decisions, within certain criteria. I appreciate them maintaining a current stratification. I think this is something we're all familiar with. And thinking about outpatients, whether or not they have comorbidities, and treatment selection, whether they're in the inpatient ward or within the ICU, and providing some guidance on, how to handle patients at risk for MRSA and Pseudomonas. So I think their overall structure and stratification really provides a good framework for identifying what drugs could potentially be considered for your patient, and also to provide some clarity, even though they may not make a strong recommendation of one recommendation over other, because they usually give a few options, some of the guiding evidence and principles which may lead you to take one drug combination over another, for example, in patients within the ICU. A couple things though, while I appreciate the move away from HCAP, and just to remind clinicians to check prior culture data, I think given the importance of getting it right the first time, I wish they were a bit more aggressive. They do recommend empirically covering MRSA and Pseudomonas in patients with risk factors for those, if they have severe pneumonia, which is basically pneumonia and septic shock. However, my fear is we may undertreat a few patients who could potentially progress to septic shock. I think their recommendation for this was based on best available evidence showing that we overtreat drug-resistant pathogens. But I still think we have to have a bit more work in that area, because there's a recommendation to rely on instituted validated risk factor scores, and this is something that a lot of institutions do not have. So I do think there's an opportunity to better kind of clarify who is our CAP patients at risk for MRSA pneumonia and Pseudomonas pneumonia, more than just having it on a prior culture or a current culture or PCR NARS test. The other thing I think they could have done is provided a bit more clarity on the role of new drugs. As I mentioned before, we have lefamulin and omadacycline. Omadacycline is mentioned twice in the document. Lefamulin is mentioned once. And both is in the future research direction section, citing limited experience with this drug. Why this is true? These two agents have gone through recent FDA guidance for approval. It's more of a focus on patient-reported outcomes, symptomatic improvement. So these are all things that are of value, and they moved away from a lot of test-to-cure assessment, which was a clinician's assessment of the patient's response. Lefamulin has 2 phase 3 registrational trials, and omadacycline has 1. So I think we could add a better defining of their roles in therapy, perhaps not as first-line therapy, but to have a opportunity to consider them, particularly in patients at high risk for a fluoroquinolone-associated adverse event. I mean, if you just look at the packet insert of the fluoroquinolones, there's a lot of class effects listed. Aortic aneurysm, patients who are over 65, cardiac conditions, hypertension, patients with renal failure, these are all at increased risk of certain adverse events associated with fluoroquinolones. So I think there was an opportunity there within the guidelines to better perhaps define the use of our newer drugs in those patients. Alternatively, they could say in those patients maybe that there should be preferential use of a beta-lactam with a macrolide. So I think these are opportunities, but recognizing that the guideline committee relies on best available agents, and with the newer agents, you only have 2 phase 3 trials, or only phase 3 clinical data, 2 clinical trials with lefamulin, 1 with omadacycline. So appreciate the need for further data, but I think what we have here now in clinical practice is we have these fluoroquinolones, which are our go-to CAP drugs. They have tremendous efficacy. You'll never have a more efficacious drug class than the fluoroquinolones in patients with community-acquired bacterial pneumonia. However, from our federal government, and this is also with the EU as well, is they identify a number of serious adverse events. Now, overall, you look at overall fluoroquinolone use, these adverse events are low, but they do identify some high-risk patient populations. So in the next iteration of the guidelines, now it's taken us 12 years to get this one. So when will this occur? I do not know. But I think all clinicians would benefit from better clarity on what drugs we should use in patient populations at high risk for fluoroquinolone adverse events, given that they have historically been one of our go-to agents for patients with community-acquired bacterial pneumonia.